Good evening and welcome to this webinar on the proposals for a change to the foundation programme allocation process in 2024. My name's Mike Masding. I'm half the time I'm a consultant physician specialising in diabetes, and the rest of the time I'm co-chair of the UK FPO and lead foundation. This is going to work is I'm going to do a short presentation about the proposed changes, and then we're going to have a panel discussion answering questions with my colleagues, Professor Amir Sam, Dr. Tom Lawson, and Ms. Elaine Colasso, who's National Programme Manager for the UK Foundation Programme Office. As you can see at the bottom, there is a Slido open if you have questions to ask. There's a QR code there. And if you go to Slido and do #allocation, you'll be able to ask questions. We've already got some questions that people sent in prior to the webinar, and we will try and answer as many of your questions as we can. In the interest of time and fairness, we will finish at 7:30, but any questions that are unanswered we will address on the UK FPO website on our FAQs site for this allocation process. So just as means of introduction, I think it's worthwhile just saying how we got to this particular point. Way back in 2008-9, there was already some disquiet about how applicants were allocated to their foundation programme posts. And so the Medical Schools Council, the UK FPO and the four nation statutory education bodies set up the Improving Selection to Foundation Programme project, which, as its name suggested, was there to help with the allocation and to make it fairer and to try and ensure good coverage of foundation doctors across the country. This website for the ISFP is still open, so if you're interested, you can go there and look at how we came about to our current situation for allocation to the foundation programme. And there's a whole lot of stuff about the evidence that was used to inform the changes, which started in 2011. And since then, there has been some iterations of the allocation to the foundation. But it's pretty much the same as it has been for 11 years, and hence the review of the foundation programme now. 50% of a mark for each applicant is made up from an educational performance measure, and whilst there has been some changes to how the EPM has been calculated, it is still consistently 50% of that mark. And then a situational judgment test consisting of somewhere between 60 and 90 questions over the time, with answers decided by a panel of experts around scenarios that a foundation doctor may come across, and that makes up the other 50% of the mark. And so each applicant receives a score, which is now to 3 decimal points, and then they are ranked according to the number of applicants. So somebody comes first and somebody comes right at the other end, and then anywhere in between. So every applicant receives a ranking. Probably one of the most significant changes was that in 2020, the SJT moved from being a paper-based test to an online test, which has been contracted to Pearson VUE for delivery, and most applicants do this at a Pearson VUE centre. As I say, that's been going for with various small changes, but the significant body of that has been going for around 12 years now. And so the foundation programme allocation review was set up in order to assess whether a different way of allocating foundation applicants to their foundation posts should take place. Chaired by Professor Liz Hughes from HEE, with representatives from various stakeholders. Any change to the foundation allocation process has to be agreed by all 4 nations, because the UK Foundation Programme, as its name suggests, is a UK-wide body, and then agreed also by the national health departments, of which there are 4 at the UK Medical Education Reference Group. So the UK FPO doesn't determine the allocation process as such, but does deliver the agreed process on behalf of the 4 nations. And the reason for us doing this webinar this evening is that the engagement of stakeholders about a possible change is now open, and there is a survey with the link on the UK FPO website to take if you have your views on what process should be agreed. It's worth pointing out at this time that there's a lot of important issues that need to be considered. One of the jobs of the UK FPO is to ensure that foundation doctors are distributed as equally as possible across the NHS. We know that some schools are much more popular than others, but the patients in less popular schools deserve good healthcare just as much as those in popular schools. And so it's important that we don't have areas of the UK that struggle to have any doctors there. And I think it's worth saying at this point, as a consultant physician, foundation year 1 and foundation year 2 doctors are really, really important for providing patient care, for providing high quality patient care, and they're very valued colleagues across the country. We know that from previous changes to recruitment across postgraduate medicine, not just in foundation, that any changes we make will affect the behaviour of applicants, although it is difficult to predict exactly what those changes in behaviour will be. So a good example would be how we have introduced changes to pre-allocation in the last few years to the UK FPO allocation, and that has led to changes in behaviour, and we envisage that if we make any changes it will change behaviour, although of course we can't predict how. It's really important that we treat all applicants equitably, whether they are from a UK medical school or not, and in the current application round, i.e. those who are going to be starting their foundation programme in August of this year, around 15% of applicants didn't graduate from a UK medical school, and this is quite a heterogeneous group of applicants. So some people from overseas who went to overseas medical school, but also UK nationals who went to an overseas medical school, and it's important that we take into account their views, and if we make any changes, what impacts there may be on that group of people. I think I would have to acknowledge on behalf of the UK FPO that the allocation process now is quite complicated with the EPM, with the SJT, with different programs such as the Specialised Foundation Programme, Foundation Priority Programmes, etc., etc. And if we can make the allocation process simpler for all those involved, applicants, medical schools, the UK FPO, foundation schools, then I think we will have achieved something. And it's clear that from the last 2 or 3 years that we've had oversubscription to foundation programs. And whilst this year the UK 4 nations have put out a statement guaranteeing that any eligible applicant who is still in the process will get a post this coming August, we do need to manage oversubscription, and it may be that through changing the way posts are allocated, we could do this better. So the current model, as I've already described, 50 points for an education performance measure, 50 points for a situational judgment test, up to a total maximum score of 100. Applicants preference all school, all the foundation schools, and then are ranked according to their score and are allocated to the foundation school according to their rank. So the person who's ranked first will get their first choice foundation school. Where there are no remaining vacancies for an applicant's first choice foundation school, they are then allocated to their next highest available preference foundation school. And this does mean that people who have scored lower down in the rank will mean that it's unlikely they'll get their first choice foundation school, or it depends on how popular it is, but then maybe bumped down their preferences as allocation continues via ranked order. The benefits are that, well, it was proposed by applicants. The cohort of applicants cohorts of applicants between 2009 and 2011 contributed quite significantly to the Improving Selection to Foundation programme group, so the SJT and EPM was approved by and proposed by applicants. It is a meritocratic process, so the person who comes first does have the highest score, the person who is lowest in the ranking has the lowest score, and then anywhere in between. And so because the EPM contributes to that, and then so does the SJT, it does mean applicants have some control over the score that they get. We pick up possible patient safety concerns, and the group of lowest scorers at the SJT have the chance to be reviewed to ensure that they will be safe as foundation doctors, and after that process some are withdrawn from the allocation. And using this over the 11 or 12 years that we've done it, a high percentage every year, over 75 to 80%, do get their top preference foundation school. The problems that we've heard from applicants over the last couple of years are detailed here. I won't read them out, but you can see there are a significant number of issues with the deciles that inform the educational performance measure, and a particular concern is a lack of standardization both within and across medical schools, and also the fact that it breeds a competitive nature detrimental to education within medical school. Situational judgment test is felt not to discriminate sufficiently between applicants. In other words, particularly in the middle, the scores are very, very, very close together, and that's why we've had to go to 3 decimal points. And also, in looking at this, in keeping with most of assessments, a lot of medical education, there is a consistent bias against people from minority ethnic groups. There is a differential attainment which we need to address. As I mentioned, the competition ratios for foundation schools differ quite significantly. At one extreme, the most popular foundation schools get 3 people putting them first for every post. At the other extreme, 0.4 people putting them first for every post. Yet in all of the patients in those places deserve good healthcare. So the allocation review group, chaired by Professor Liz Hughes, have come up with a proposed different model, which we call the preference informed allocation. In this model, applicants will not have a score, they will not sit the SJT, and they will not have a decile or EPM score. The ranking will be entirely computer generated via the Oriel system, so there will still be a ranking, but it'll be entirely computer generated, and all applicants will have the same opportunity to be first and then any number through the ranking. There'll be a slight change to the allocation in that applicants will still preference all foundation schools. The allocation process will allocate as many applicants as possible to their first preference, and any remaining applicants who haven't got into their first preference will be allocated to the next available foundation school of their preference via their ranking order. So we think that more people will get their first preference than possibly now. We feel that feedback from the medical schools is that this will remove some stress from the allocation process, and particularly the stress around EPM and sitting the SJT. It is fair in that all applicants will have a chance to, according to the computer generated ranking, and we can run the algorithm a number of times to achieve the highest number of applicants receiving a first preference. We've modelled this using data from 2021. In the blue are the number of people getting their first choice foundation school according to the current system, using the score from the EPM and SJT. And if we did it according to preferencing, using a computer generated ranking, is what are the bars in red. And you can see that more people get their first choice using that compared to those who using the score. And then down the other end, the scores are very similar. What are the risks if we move to this? Well, the previous low scoring applicants not picked up by the wouldn't be picked up because they wouldn't be sitting in SJT, and so there would possibly be a risk of some poorly performing applicants being admitted to the foundation program, which they wouldn't have been before. We fully appreciate, as I mentioned before, that preferencing behaviour may well change, and so the model may change in terms of the numbers, and it may increase competition at the most popular foundation schools. We realise that any change will drive anxiety, and that's why we're trying to communicate these changes by webinars such as this and the materials we put on our website. And if you haven't read those yet, then please go and see them. And there may be an impact on foundation priority programs, as we will see. Just to try and ameliorate some of the myths that I've heard throughout my time in the foundation program. One is that applying to a more popular foundation school should be done because it has better posts. What I've done here is correlate the competition ratio. So at this end, these foundation schools are extremely popular. They have 3 people per post, putting them as first choice. And then the converse here, so these are the least popular schools. And then I've used data from the GMC National Trainee Survey in their F1 year in medicine of overall satisfaction with their F1 post. And you can see there's no correlation at all between overall satisfaction with the post and with the competition ratio. In other words, more popular foundation schools do not have greater levels of satisfaction with their F1 posts compared to those that are less popular. And the same is true if we look at surgery. It's not just in medicine. Exactly the same is true. Indeed, you could probably argue that the less popular schools over here are actually provide a greater level of satisfaction than more popular schools. Another thing I've heard is that being in a popular foundation school means I'm more likely to get into specialty training. Well, this is from a few years back, looking at FY2s going into specialty or GP training. And again, you can see no correlation at all about the percentage of F2s going into specialty training with competition ratio. So those in a less popular school are just as likely to get into specialty training as those from a popular school. So just to finish this presentation, please remember that there is no process where everyone will get their first choice. We know, as I've mentioned on a number of occasions now, that some schools are more popular than others, but it's our job in the UKFPO to ensure that there's a good distribution of doctors throughout the NHS to ensure high quality patient care. We've got good evidence that you will get supported and well trained wherever you do your foundation program, so that will not be affected by how popular a school is. And in order to allow consultation and to embed any changes in the foundation program, if we do make any changes, they won't be, just for a year or two. We will need to make them for a few years so that we can evaluate any changes that has made. And as I say, the current SJT and EPM have been in place now for 12 years, and they weren't just brought in on a whim. They were brought in with the support of applicants after a very robust process in order to look at all the data that was available. So that's the end of my presentation. So I'm now going to welcome the panel, Professor Amir Sam, Dr. Tom Lawson and Ms. Elaine Colasso. And what I will do is I will read out a question and address it to a specific individual, and we will discuss the answers as we go along. So the first question for the panel, and I'll perhaps address this to Tom, What happens if there are less jobs than applicants? In other words, if the foundation programme is oversubscribed as it is now?
Thank you, Mike. Good evening, everybody. I think the proposed alternative model assumes that we will continue, as we have to this point, in guaranteeing a post for everybody who's eligible for foundation training. That statement has gone out this year, that everybody who's eligible for foundation training will be awarded a post. We don't envisage that position changing. Of course, we cannot look too far into the future, but as things stand now, there is a commitment across the 4 nations, and given the demand for doctors in our system, I find it very hard to believe that in the near future we will be looking at a situation where we're not desperately trying to recruit everybody. Thanks, Mike.
Thanks, Tom. The next question is for Amir. Will the UK MLA, the medical licensing assessment, be used as a ranking tool when it's introduced? Could that be used for allocation to foundation programme posts?
No, the MLA will not be used for this purpose. The MLA is to demonstrate that those who are obtaining GMC registration with license to practice meet a safe threshold, and therefore it is not designed to be used for the purpose of ranking and job allocation.
Thanks, Amir. Next question to Elaine. If we introduce preference informed allocation, what happens to specialised foundation programme and foundation priority programmes? Will they continue, and how will they be assessed?
Thanks, Mike. So if preference informed allocation is adopted, then we anticipate there might be some changes to SFP, because currently local foundation schools do use EPM. Some of them do use the EPM for long listing candidates, and that would obviously need to change because we wouldn't use the EPM any longer. So the process in that area might change. For example, we might have changes to the questions that we put into the application form for SFP. In terms of FPP, I think if PIA was adopted, so the preference informed allocation, we would look to review the effectiveness of the FPP programme and check it's still fit for purpose in order to ensure that's right to continue with it. So there may also be changes there.
Thanks, Elaine. Yes, they will be very much open to review as part of this, and certainly specialised foundation programme. We will look to maintain the academic elements of that. We certainly don't want to lose that. A pipeline into clinical academia is really important for our whole profession. But we need to ensure that specialised foundation programmes, as they currently run, do achieve that, and also whether they're achieving it in the right way. Okay, question for Amir. Have you thought about the effect of applicant behaviour changing with preference-informed allocation? Won't oversubscribed areas get many more applicants, leading to more not getting their first choice?
Yes, that's a possibility. So, for example, more people might go for North East London, that is oversubscribed. So those people whose computer generated rank does not allow their allocation to their top choice will then get their second choice, or the third choice, or the fourth choice. So if everybody decides to go for a particular foundation school, there's obviously a limited number of jobs in that area. And therefore, it would not be wise, for example, to put 5 places where you think are going to be oversubscribed as your top 5 choices.
Okay, thanks, Amir. Yes, I think it's really important. And but as I mentioned during my talk, it is difficult to be absolutely sure how applicant behaviour will be. And indeed, you know, those of us who've been in this for some time can remember that applicant behaviour changed when the SJT and EPM were introduced all those years ago. So it will change, and we will need to assess the success of the allocation process after it's been introduced. One for Elaine here. What happens to linked applications if preference-informed allocation occurs?
Sure. So we linked allocations would continue, but we would anticipate the process happening in the same way. So it would be based on the lower ranking applicants' allocation as it does now. So that really wouldn't change.
Just to be absolutely clear, applicants can link their applications, so they will both be allocated to the same foundation school, and most foundation schools under those circumstances will also try and put them in near or adjacent hospitals, but in the interests of fairness, it will always be that the linked applications will be at the ranking of the lower ranked person. So it's not a way of trying to jump up the rankings, and that has always been the case with linked applications. A question here. I've worked hard to get into a competitive region or to go home. Will my achievement now not count for anything under preference-informed allocation? What would you have to say to the person who's asked that?
Lots of good questions coming out, Mike. I think, my perception of achievement in medical school is not really about getting into foundation. I know that is the immediate priority for students, is about where they want to be for foundation, but all the achievements you gain in medical school have a much longer lifespan than the application for foundation, and are much more fundamental than just that process. So I do hope our students are seeing the benefits of their achievements in medical school in a much wider context. As you mentioned in your presentation, and I can't, I'm speaking here today as the postgraduate dean from Wales, really as one of the recruiting nations, and our priorities are, of course, that we support applicants to get to where they want to be, and for regions like ours where the application ratio is perhaps not as high, or less than one for every post, then of course the process works well, in that I'm keen that everybody who wants to come to us gets to come to us. That's a really important part of it. But you also mentioned, Mike, it isn't just about each individual here. It is very much about the system and the importance that we're going into public service and filling all our posts. So, it's about devising a system that works for applicants and that wider system. And your achievements will always be recognised. They are not just about getting into foundation, which you will do.
And foundation, it's fair to say that foundation doctors achieve a lot during their foundation programs. Not most importantly, they achieve good patient care and contribute to good patient care, and that is the biggest achievement that any doctor can do. Now, sometimes that's with the patients in front of you, sometimes that's with groups of patients, or sometimes it's via a multidisciplinary team. But nonetheless, I think it's fair to say that the biggest achievement that any doctor can do is contribute to patient care. Amir, as the head of a medical school, what would you say about that question about will achievements not really count for anything under PIA?
I just want to echo what you said, Mike and Tom, about achievements, and the lifespan of achievements goes beyond the foundation year. So if you are driven by doing well in exams and distinctions and merits and prizes, they will still exist. All medical schools will continue to recognise achievements as far as exams are concerned. They're not going to disappear. What is going to disappear, if a preference-informed allocation is adopted, is the unhelpful competitive environment, which actually is prohibitive and detracts from the main purpose, which is achieving good patient care. So you can still excel and do well, and those will be recognised, but at the same time you'll have that freedom, that peace of mind to be able to engage with real clinical experiential learning, free from the stress of ranking.
Yeah, and we've heard that very clearly, what stress the SJT induces, the EPM induces, and looking at the group of applicants as a whole, and this year there are currently 9,700 people currently in the process for August 2023, that we care about all of them. If we can make the process simpler and less stressful for all of them, then actually we believe that it'll be better in the long run. I'll answer the next question. Will there be more applications to pre-allocation, SFP and FPP? Possibly. Again, we can't predict what behaviours will happen, but there may be. Fully appreciate that as things stand, with specialised foundation programmes being allocated earlier, a consideration for some applicants is that it gives them certainty of geography about where they're going to be. Although, of course, we would prefer people to be applying for specialised foundation programmes because to get some experience of an academic or education or leadership role and see whether it fits them for the SFP applicants. We shall see. As regards pre-allocation, that's again something really important to us, to try and help those who need to be in a certain geography to uncertain criteria to facilitate that. And it may well, again, we get more pre-allocation applications, we don't know. But pre-allocation is very important to us. It's something that's under review every year by the UKFPO as to the criteria and how we manage it. And this year we've had a large number of people who have been successfully pre-allocated to foundation schools, or will be successfully pre-allocated to foundation schools to start in August 2023. And the pre-allocation process certainly will continue. As Elaine has already mentioned, we will review the effectiveness of foundation priority programmes. This will be the, I think, third or fourth year we've done it. So it's about time that we did review whether it's effective in what it's trying to do, which has largely been around trying to attract applicants to places that have previously struggled to attract, or indeed specialties that have struggled to attract. So we will be reviewing FPP as part of this process and seeing about its effectiveness. Another question here, and I apologise if I didn't explain this very well, but perhaps Elaine can explain. What does computer-generated ranking mean?
So with a computer-generated ranking, it's simply the system assigning a rank to a candidate. So if there are 9,000 candidates, the system will assign a rank 1 to 9,000 to those 9,000 candidates. It's not based on any specific criteria. It is simply an allocated number that each candidate will get. But like I said, it's not based on any other specific criteria at all. It's just a rank they're given.
And it would be that each applicant would have the same chance of being allocated numbers 1 and 2 and so on and so forth. Be no weighting, or there would be no we would have no input into it. It would be done via the oral system, I think. Elaine, is that right? Okay. So it is, as its name suggests, a ranking by a computer, as opposed to using the SJT and EPM scores. And again, just to be absolutely clear, if the PIA process is adopted, there would be no SJT, there would be no EPM. Okay. A question for Amir. Have you done enough modelling? Should you be doing a dummy run with current students?
So we did some preliminary modelling at Imperial to look at the proportion of applicants who would get their first choice, second choice, etc. That modelling was then again repeated by HE independently, and they got very similar results to us. And the results, the summary was presented by Dr. Masding. I think it will be very difficult to run 2 systems in parallel. There will be ethical implications. How do you decide, who do you allocate to system A versus B? So you need an engagement exercise. You need to consider both models and then decide what's the next best step, in my opinion, and then go with that. It'd be it will raise serious ethical issues of having 2 parallel systems for different candidates, I think.
Thanks, Amir. I'll stay with you, and then I'll bring in Tom on this question after you've finished. If PIA is brought in, why are you rushing to implement it in 2024?
If a decision is made that PIA is a better and a fairer way of doing it, I would reverse the question is, why wouldn't you do? So, for example, if the student body and the stakeholders look at the advantages and disadvantages of the two, and then in the end you conclude that, for example, the new system is not associated with the bias that's associated with the other scores, or if the new system circumvents the problems associated with the ranking, the competitive culture, etc., then why would you wait and not bring in the benefits? Vice versa, if you think the current system is the preferred system, why would you bring in a new system? So I think you need to consider the options, decide what is the best option, and then once you've made a decision, you would go with that.
Thanks, Amir. Tom?
Yes, I think I should probably state at this point that personally, I'm yet undecided as to one of these options, and the engagement exercise that we're embarking on tonight is very important in informing where we go. And just reiterate, Mike, that what you said is it's not UK FPO to decide this, it's for the 4 nations and their departments of health once the whole system's views have been assessed. But I would echo Amir's comments. If the decision is made to move to the preference-based system based on all that evidence of fairness, etc., then it's not as if we're introducing something that requires preparation from the candidate, from the applicant's perspective, which I think is a key thing. I think if there was a new test or process that required some sort of preparation on behalf of the applicants, I think that would be a very different scenario in terms of the time frame. But the fact that this approach would remove that perhaps takes away some of that issue about the time lead in for that change. But I accept that many people have been in medical school for a while, anticipating that the system that they're going to be embarking on soon, and any such change in a short time is stressful. When we've been talking about stress already, then that is associated with stress for individuals, and we should acknowledge that.
Thanks, Tom. A couple of questions that I will quickly answer. There's one here about pre-allocation, and just to reiterate that we absolutely will be running pre-allocation under any process program to help those who absolutely need that help. I don't envisage that will change. There's a question, we're widening participation or widening access to medicine graduates of courses who've entered medical school under those circumstances. Will pre-allocation still apply to those? Well, certainly we've got no plans to change that. We need to review how that affected pre-allocation this year, but no intention to abandon that at all. Elaine, a question for you here. It says, will we find out our rank before preferencing under a PIA system? No.
So currently, the rank, it would happen in the same way. The rank isn't announced before candidates' preference, and the same would be the case with this allocation model. Applicants would have to preference before finding out their rank. There are various reasons for it, but there are withdrawals even before the allocation happens. Applicants withdraw themselves, they are withdrawn from the process for several reasons, and so we have to take the data on the day and rank on the day to make sure it's correct, and that's why the rank can't be announced ahead of time.
Thank you. The question, would the proposed change affect international students? Well, it will affect all applicants. Those who apply from overseas, both UK nationals and citizens of overseas countries, are extremely important to us. We want to treat them absolutely equally to UK medical school graduates, and the UK has a history of training people from overseas, and we really appreciate the service to patients that those doctors provide. So any change, well, it would affect international students, but no more than those who are UK medical school graduates. They will all be part of the same ranking, and just as they are now. Tom, an interesting question. Why is the foundation programme selection different to other healthcare roles? Why can't we apply to specific locations for jobs like physios or nurses?
Well, that is a good question, Mike. And of course, with foundation and the provisional registration status and the scale of what we're talking about here, with 9,000 people coming out of medical schools at the same time, to have a local recruitment process to individual places for something of that magnitude would, I think, be very challenging and potentially less fair across the system.
And it's also worth saying, of course, that nurses and physios don't have a pre-registration year. UK medical school graduates have to do an F1 year to gain full registration and thereby go on and practice as a doctor. So if you're graduating from a UK medical school, you don't have any choice but to do an F1 post. That's in the law, the Medical Act from 1984, but was originally adopted in 1948, in fact. And so, you don't have any choice. You have to do an F1 post. And what we want to do is try and apply an allocation process as fairly and as equitably as we possibly can. Amir, how is patient safety going to be prioritised with the removal of the SJT, which captures low scoring candidates who are a potential risk to patient safety?
Okay, so academically, we could debate the evidence base for SJT predictive utility. I will obviously present to you the data that we have got, and others will have different data. So we looked at 35,000 physicians in the UK and looked to see whether the SJT was predictive of disciplinary action. For example, the doctors receiving cautions or undertakings, even erasures from the General Medical Council. And the SJT was not predictive. So that's one paper, and there'll be other bits of paper that's showing some predictive utility. I think if you believe that the SJT is detecting something, you need to be doing it earlier in the medical school journey and provide time for remediation. Doing a test in December, January of the final year leaves us virtually no time to remediate and help and support the students with low scores. So if you think that the SJT has got predictive utility and there is data suggesting that, contrary to what I've said from our findings, then I would like the SJT to be run earlier in the course in the medical schools and allow us to remediate and support the candidates.
Okay, thank you. Elaine, as National Foundation Programme Manager, what will happen with the cost savings from running the SJT if PIA is adopted?
So I think we want to be clear that cost savings was never one of the drivers going into looking at the allocation model. It was very much based on the feedback we were receiving around using the SJT and EPM as part of the allocation method. There will inevitably be some cost savings from not running the SJT, but as you can imagine, in any large education system for healthcare, there will inevitably be areas where we can put the money back into ensuring that education is well catered for upcoming doctors and other healthcare professionals. So there will be cost savings, yes, but they will be put back into the system.
Thank you. Yes, and I absolutely want to confirm that when we started the review, it was on the basis of feedback from applicants and medical schools, particularly around the issues around the stress caused by the deciles and the educational performance measure, some behaviours driven by the EPM, which we may not particularly want from doctors, and the particular stress caused by sitting the SJT. In addition, as I mentioned earlier, around 12 years since we introduced the EPM and SJT, so it was due for review anyway. And at no time at the start of the review was cost an issue, and that has not been a driver at all. It is on the basis of trying to do the best for applicants. Amir, here's one again. As the head of a medical school, you might be able to answer, and I suppose the answer will depend upon which medical school. But will the removal of deciles mean that we get degree classifications instead?
No, I don't think the two are linked in any way. Remember, the universities will have their own independent regulations, and this is not interlinked with your degree. So these are separate conversations. Mike, is it okay if I just address one other thing?
Yes,
here, which someone's written specifically in the chat for me, says, so should applicants tactically rank their choices under the proposed system? I don't think there is any tactic that I can think of other than we know that 14 or 15 out of the 1920 units of applications have a competition ratio of less than 1. So in about 80% of the jobs, there are actually more jobs than applicants. So the only tactic that I think would be, the only thing I think would be unwise to do is to put your top 5 choices, the top 5 places which are currently having a competition ratio of more than 1. So if you put those as your top 5, then if more people have gone for those, you're less likely to get your top 5, and that's common sense. Beyond that, I'm not sure how the new system can be gamed.
And we publish the competition ratios. They're available for anyone to look at. So, you know, if people want to look at that and study it, going back to, I think, around 2012, 2013, that data is available if you hunt for it on the UKFPO website. And we would certainly have the up-to-date competition ratios from any previous year as we move on through this process for people to look at and make a decision on their ranking preferences based on data rather than just you know, a random guess. And we will certainly be publishing competition ratio data every year so people can have a look at that. Tom, perhaps you might like to comment on this one. Is there a way to prioritise UK university grads for preferencing over international medical graduates as the number of IMGs increases year on year?
Thanks, Mike. So as things stand, we are treating all applicants to the foundation programme equally. We are not discriminating between international medical graduates and UK graduates. I think the concern that's coming through there is, do we envisage a situation where a UK graduate might not get a job at some point from medical school? And I think the bottom line for that is that would not be acceptable for any of the nations, particularly given what you've said around the fact that graduating from medical school gives you provisional registration, and you have to do the first year of foundation to achieve full registration. I cannot envisage a situation whereby funding to put somebody through medical school would end up with any of the nations not supporting them through to the point of registration. So I think the point is, currently there is a desire across the 4 nations to ensure there are sufficient jobs for all applicants, and therefore the whole issue about prioritisation is not something that we are currently addressing.
Thanks, Tom. A question for Amir. Why should better academic performance justify preferential allocation anyway?
So that's a good question. Currently, I'm not aware that in any medical school, students are allocated to their placement based on their exam scores. So you're all allocated to various placements in various areas of clinical practice, medicine, surgery, obs, gynae, peds. We don't use your exam performance to say you're going to this hospital versus that hospital. You are allocated to different hospitals, and it is assumed that you will receive adequate training in all of those hospitals. So by the time you're an F1, you should be competent, and all the jobs should provide valuable training. So I think one of the unintended consequences of the current system is this narrative that some jobs are more superior. And as someone working in North West London, which happens to be very competitive, I can assure you that the training that you receive in North West London is not better than the training you would receive elsewhere. And therefore, I don't agree with this narrative that if you worked hard, you need to be rewarded by being placed in a job that is more competitive. Now, there may be other social reasons why some jobs may be more competitive, but as far as training is concerned, all jobs should provide valuable training, and you should all be competent F1s.
Yes, and the foundation school directors, just to add to Amir's comments, the foundation school directors, foundation program directors within hospitals work extremely hard to quality assure training and ensure that all foundation program doctors have the opportunity to achieve the curricular outcomes, complete their foundation programs, and go on into their future careers in medicine. And indeed, if we look at the outcomes of foundation programs, well over 99% of foundation doctors have successful F1 years and have successful F2 years and go on to become doctors in whatever field it is they want to do. So you know, the allocation of where you are will not affect your chances of getting through the foundation program, and as I showed, competition ratio doesn't correlate in any way with satisfaction with the training received. Amir, this is another one for you. Please could you explain how you have predicted 80% of applicants will get their first ranked foundation school or deanery?
So it's not predicting, it's modeling. So essentially you go as Elaine explained, you would give a number between 1 to 9,000. So if your number happens to be 1, you will get your first choice, and then depending on your number, the system will look to see whether the job, your first choice, is available. If it's already been taken up, it will give you your second choice if it's available, and then it will work down the list. And when we put in the data from the previous year into this model, nearly 80% of the people got the jobs that they had gone for. Now, if in the new system more people go for the more popular jobs, the more highly ranked jobs, then you will then get the more people get their second choices or third choices, etc. So it's very difficult to predict what would happen when you roll this out in real life. But based on the current data, the modelling shows that 80% would get. And I think one way of understanding this is that there are areas in the UK where there are more jobs than applicants. So the competition ratio, which is publicly available, you can look it up, is less than 1, so more jobs than applicants. And because of your score from the EPM and SJT, you are then allocated the job that you don't really want to go to, for example, whereas the job that you want to is available to you. So if you eliminated that EPM SJT score and just said, okay, where do you want to go? If that job is available, here it is, then more people would get their top choices.
A number of questions again about the timing of doing this. Why not wait until those who are going to start medical school in September 2023 and will come out in 27, 28, 29? Why not start it then? Why are we doing that now? Perhaps I'll let Tom go on that one, and then perhaps Amir as well. I know we have said all this, but just to reiterate some of the reasons behind it. Tom.
I think the reiteration, Mike, is that a decision on what the allocation model will be has not yet been reached. The earliest timing that it could be done would be for 2024. And if the support across the system was to change to a preference-based allocation, it's difficult to argue for delaying rolling out if that's considered a fairer, more transparent, because we are not asking people to undertake any other assessments for it, would be the view for that. But again, just reiterating, I do appreciate that a change when people have been expecting something for some period of time is stressful, but I'm not sure that that would be reason enough to defer for several years.
Amir?
So one of the questions I am frequently asked by our students is that given the fact that you've seen the detrimental effects of ranking on the student, the competitive culture in the medical school, and given the fact that there is data published since I think 2013 showing that there is a differential attainment between the BME candidates and the UK and the white candidates, is all UK born and bred candidates, but there is a significant difference between the two cohorts. How can you ignore this? So if you believe that there is discrimination and the data that's been published suggests that, then you could reverse the question, say, would it be justifiable to wait 3 or 4 years when you know that the system is flawed and it is discriminating? it would be very difficult to justify that. And that's one viewpoint from the candidates who say it is not ethical to wait, in the same way that if you know that a drug has a side effect that is unacceptable, you wouldn't wait 3 years before you withdraw that drug. You would want to do that as soon as you're sure. And obviously that decision needs to be made. And then once it's made, it will be implemented by UK FPO.
Thanks, Amir. And I can only reiterate that the differential attainment that we found is there in both the educational performance measure, so what is happening at medical school, and also what is happening in the SJT. Now, the statutory education bodies take different things extremely seriously. Evidence out there as to why it happens, and it's very complex in terms of the fact it's not just about people being deliberately discriminating against certain groups, but there's lots of evidence about different types of preparation, different types of role modeling by senior people, and it's something that the GMC have asked the statutory education bodies to address in postgraduate medical education and undergraduate medical education over the next few years. And we're working very hard to do so. But as Amir says, where we find evidence of this, it is then very difficult to justify just carrying on as we have done. A couple more questions before we finish. A quick one. I'm not sure I understand what this alludes to, but it says, for Amir, are you sure the algorithm method won't cause problems like it did when allocating students to universities in 2020? I don't know what the last bit alludes to, but I guess it was something to do with the pandemic.
Presumably, they mean the centre assess grades.
Yes.
So that's a different paradigm. Here we are. The assumption is that every graduate is competent to be an F1 because they've been through the assessments by the medical schools and in future the MLA to make sure they're competent, and all the jobs provide valuable training for everybody. Admission to medical schools is different. You have nearly 30,000 people applying to do medicine, and you do not have 30,000 places. So you will have to draw the line somewhere, and then you need to have a tool that will allow you to admit the students into medical schools. At the other end, as Dr. Lawson has said, you would ideally hope and want to see every graduate be allocated a foundation training program, and there shouldn't be a situation where some people are allocated and others aren't.
Yeah, and we absolutely have to make sure that all applicants are allocated, as Tom said earlier. Final question now for Elaine. When will a decision be made? What's the sort of timelines on this?
Sure. So at the moment, the engagement's still very much live. We have a survey running, and the link for that is on the UK FPO website. And that is your opportunity to share your views. Both organisations and individuals can answer that survey. So we really strongly encourage everybody to go and please use that survey to engage with this discussion. That is open until the end of February, so until the 28th of Feb. At that point, we will analyse all of the data that we've got, all of the responses that we've got, and then the 4 nations will look at all of that and make a decision. And to be clear, it isn't UK FPO making that decision. That will go to the 4 health bodies to decide on what happens and which allocation method is used going forward. A decision is anticipated towards the end of spring 23, and we will of course publish the findings and the decision on the UK FPO website.
Thanks, Elaine. And I'm now going to bring this webinar to a close. Thanks very much to all of you who attended. I hope it was of interest. I hope it stimulated some thought and discussion about the allocations to the foundation programme. I'll just reiterate that we're never going to come up with a process that pleases everyone, but what we do want to do is try and come up with a process that pleases as many people as possible. I'll reiterate the point that a number of the panellists and myself have made, that you will receive high quality foundation program training wherever you go that will allow you to achieve a successful foundation program and go on to, I'm sure, a successful medical career as well. Your views are important, and we will take them into account. There is a link on the Slido now to the website page. If you go to the UKFPO website, it's there. Please complete the survey and give us your views. I'll finish by thanking very much the UKFPO team for setting up this webinar. Really appreciate your efforts, and thanks very much to Dr. Lawson and Professor Sam for giving up their time to come and give us their views, which have been really, really valuable. So I wish you all a good evening, and most importantly, I wish you a successful final year for those of you in your final year, and I look forward to seeing you in the foundation programme and as you go on throughout a successful medical career. Thanks very much. Goodbye.